Welcome. My name is Teresa Schmidt, and it's a pleasure to present to you one of my favorite topics, integrated neuromuscular reeducation. It's become one of my favorites because I've seen fabulous functional outcomes when including these techniques in my practice, and hopefully you too will be equally excited when you see the results you generate. Great thing about it, the objective results we get are very measurable and very easy to document, which makes it nice and easy for billing purposes as well. So we'll go over a little bit about documentation, how you can see a change immediately with many of these techniques, and then how you can see changes in not only pain, which is pretty immediate, about 90 seconds time, but you can see changes in strength, range of motion, and functional ability. Most of today's techniques are highly adaptable to different positions. Many of the same techniques can be done in supine, prone, sitting in a wheelchair, very adaptable for home, school, or clinic, so easy to work with. This morning's topic is going to be positional release therapy, and positional release therapy is also called strain counterstrain. That's a technique developed by Dr. Lawrence Jones, in which we look for trigger points or tender points in the body, and then we use different positions to erase or modify those tender points or trigger points. So it really does make a nice difference immediately in the sensitivity of the muscle and in the muscle tone. Now, I've been using these techniques. I've been a physical therapist for 23 years. I'm board certified in orthopedic physical therapy, so the bulk of my practice is outpatient, although I've worked in most types of physical therapy places, whether it's schools, clinics, or hospitals, and you can modify and adapt most of these techniques across the lifespan, regardless of what type of site you're working in. They could be done on a table, they can be done on a floor. You know, oftentimes you're working in a school, you're on a mat, maybe in the gym, so very easy to modify and adapt the techniques. You need to know that there's a little bit of a neurophysiology background to everything we do today. Understanding the concept of why these techniques work will allow you to then start to create some of your own techniques for the future. By the end of this morning, you should have a good concept of how does positional release work, what are the muscle actions, and then how can we actually reproduce those to get a great release of trigger points and tender points in the body. And let's start a little bit with the introduction of neurophysiology. We're all movement practitioners, right? Okay, so we all work with muscle. At some point in time, we've gone through the torture of memorizing over 400 muscles in the body, right? Origins, insertions, innervations, actions. So it's important to remember those. And who remembers exactly where the omohyoid is anyhow, right? Or what it does. But that's okay. I will refresh you as we go through the day with the demonstrations. What are the muscles we're working on? What are their actions, their attachments? Because knowing exactly what the muscles do helps you be precise in doing everything we're covering today with a patient. And it helps you be quick, right? Sometimes with mismanaged care these days, we have very abbreviated treatment times. You might see someone 6 or 8 visits and their insurance cuts them off. So we need to give them as much good intervention as possible and then move forward from there. Get them into some functional home exercise programs, things that help them get back into their work, their recreational activities, back to the life they love. So that's what we're really looking for here. We all treat muscles. People come to us, they make appointments because they have problems with their muscle length. Muscles are too short, they're stiff. Muscles are weak, they're having trouble getting out of their chair, trouble walking, getting up and down stairs. So these create functional problems. We're going to address the muscle length problems by looking at the neuromuscular reflexes. I like to tell my patients, you have built into your body a security system. It's an automatic system that protects you from tearing up your muscles most of the time. But when there's a problem with those reflexes, maybe someone's been subjected to a disease, abnormal stress, tension, something happens with the body, muscle length becomes disrupted. And the reflexes that govern the muscles, that protect the muscles, go crazy. So you see some aberrant muscle behavior, you see hypersensitivity of the muscles in terms of movement, they're getting tighter. Some patients will come in and tell me, I feel tight, even when they're hypermobile. You're looking at it, you're not really tight, but I feel that way. So that's something you want to be able to look at. We'll look at our monosynaptic reflexes and our proprioceptive reflexes. With today's interventions, we're going to tune into those reflexes, modify them to help people move more easily, more functionally. So let's look inside the muscle spindle. You remember the muscle spindle has within it extrafusal and intrafusal fibers. Inside the muscle spindle, the extrafusal fibers send information to the alpha motor neuron in the spinal cord, and when they get too excited, that makes the muscle contract. So it's a facilitatory influence to the muscle. It responds to changes in the length of the muscle. If a muscle's getting too long, what might happen? could be damaged, right? Could tear. So we need to know that the muscle can contract to protect itself if somehow there's an external force causing too much lengthening. Intrafusal fibers go into the gamma motor neuron system in the spinal cord, and what those are really doing is telling the muscle, okay, you need to contract because not only is the length changing, but the rate at which that length is changing might be too fast, too slow, and especially if the muscle is lengthening too quickly, it's hard to control that, hard to prevent the tearing. So both of these systems are our alarm systems. When they become upset, it makes the muscle hypersensitive to stretch. That sensitivity to stretch is called muscle spindle bias. All the muscles have a preset neural sensitivity to stretch, and when there's an injury, this becomes disrupted. Other receptors are known as the Golgi tendon organs. These have the opposite effect. Golgi tendon organs are present in the ends, the attachments of the muscle at the tendons, and they monitor also the muscle tone, but when they're stretched by, say, a sharp, sudden muscle contraction, that's going to inhibit the muscle. It lets the muscle know, well, don't contract too hard because you might tear the attachments, the origin and insertion. So Golgi tendon organs are also a good security system, but if they're hypersensitive and they keep firing, they're going to weaken the muscle through this consistent inhibition. So we could look at both sides of the extremes. You could either have muscle spindles exciting the muscle, making it too sensitive to stretch, very reactive, or Golgi tendon organs becoming hyperstretched and inhibiting or weakening the muscle. And we'll be working with both of those. This whole process is called facilitation. Stress overexcites the nervous system, whether it's a stress from a disease process, trauma, some kind of abnormal tension is developed, and that overloads the spinal cord. Sometimes those afferent impulses are so great that they go into multiple levels of the spinal cord and start expanding into other segments of muscles that possibly weren't involved in the injury. Then you see these crazy things developing like complex regional pain syndrome. You've heard of that. This can happen at both at the local level, which is the myofascial level. Individual muscles will develop trigger points, tight bands in the muscle. We call them taut bands, right? If they tighten for a long time, they become fibrotic and thickened. That sometimes you get that crunchy feeling in the muscle. So this is something that happens at the local facilitated segment level, maybe a single muscle. Also, it can happen across many segments of the spinal cord. If there's so much pain and so much afferent input into the spinal cord, it overflows into other segments. And you get what's called a segmental facilitated reflex. This will also start affecting the autonomic system, which is also supplied by those segments. You'll see some vasoconstriction, changes in the skin. Okay, pain levels increase. So a lot of other things are happening. Say you overdo it. I did this one day. I decided, gas was really expensive this summer. It was like $5.50 a gallon, and I have a boat. So I love to take the kids. I get all my nieces and nephews, pile them in the boat. We go out. But at those prices, we decided, let's try rowing. So now I haven't rowed in a few years other than, a little raft. So we're rowing. You go out for an hour, and I'm rowing. We're having a great time. Kids are loving it. Beautiful day. And I decided after rowing out for an hour, oh, look at the time, we have to go back. Now what do I have to do? Row all the way back, but my biceps are already screaming, oh, you didn't prepare for this. Here's my biceps with a giant trigger point, sending afferent impulses into the spinal cord saying, moron, shouldn't have been overdoing it, you should know better, right? The next day I go to treat my patients, and I have them on the table, and I'm trying to reach, and I can't extend my arm because my biceps is so tight from all that overstretching and pulling repeatedly, the overuse. And that's what happens. We get too many afferent impulses with the pain into the spinal cord, sending efferent impulses back, telling the muscle to contract to protect itself, but also vasoconstricting in the area. And that vasoconstricting is that autonomic response. That decreases the oxygen, adds to the pain, and can further add to this pain cycle that we often see with trigger points. We like to interfere by treating those trigger points with the strain, counterstrain, or positional release therapy. Trigger points are defined by Dr. Janet Travell. Dr. Travell's book, The Trigger Point Manual, defines trigger points as a hyperirritable area lying within a muscle or its associated fascia, that when you push on it, people might twitch, they might jump, they make noise, right? They start screaming, ow, that hurts, that hurts. So you have these hidden indicators that there's a dysfunction in the body. And that's what we're defining as trigger points. That's what we're looking for today in our assessment. Trigger points have actually been studied on EMGs, and many of these studies are showing that there is a persistent contraction of selected sarcomeres within the trigger point area. Not the whole muscle contracts, but some of the cells at a time. And when that happens, you have too much calcium buildup. Remember that calcium makes the muscle contract, right? You use that up, you start using up oxygen, create ischemic responses, more pain, which gives more impulses to the spinal cord to protect and tighten up, which causes more contraction, more ischemia. So you have this pain cycle. We're looking to break that pain cycle that's indicated by the trigger point using today's techniques. Now here's what it looks like if it's overflowing into several segments of the spinal cord. This is a good example that I've seen in the literature in the Journal of Manual and Manipulative Therapy by Collins et al. And they had a girl come in who was 14 years old. She was healthy, had a simple ankle sprain. Now, I would be thrilled if someone came into my office with a simple ankle sprain. I see people with like 5 different diagnoses, and they fell down the stairs, and they had a car accident last year, and on top of that, they have fibromyalgia, so they're a trigger point from head to toe, right? A little more complex. Get somebody in with a simple ankle sprain, they're in, they're out, your statistics look great, right? But this girl did not have that situation. They did standard physical therapy. Oh, let's get some modalities on there. We'll get the swelling down, we'll brace her, partial weight bearing. Instead of getting better with the standard therapy, usually works, right? She was getting worse. Instead of the pain just in her ankle, it started becoming painful throughout her foot, up her leg, and becoming more and more sensitive, swollen. You know how the skin gets somewhat bluish sometimes, shiny, glossy, and that pain was so sensitive you could barely touch her foot. So what situation are we describing here? RSD, right? Reflex sympathetic dystrophy. In the newer times, they call that complex regional pain syndrome. If you're an antique, you might remember it's called Sudex atrophy. So that's an older name. They keep changing the names to protect the innocent. So this is what she was developing. They decided, let's try something to eliminate some of this tenderness in her leg. And they used strictly strain counterstrain. It was the only intervention for a period of time. Typically 30 to 45 minutes, a couple days a week. Significant results. She was able to tolerate movement again, increased her range of motion, increased her strength, got back to walking, and of course got back into normal exercise programs with the physical therapist. In this situation, the original trigger point was sending the usual impulses into the spinal column, sending impulses back for protection, tightening up, vasoconstricting, but the pain somehow radiated across many spinal segments, sending messages to other muscles, creating secondary trigger points. And those secondary trigger points, with their spasm, more vasoconstriction. Interesting though, if you remember in the autonomic nervous system, that travels through the spine as well. So if you have impulses going in, not just the muscular system will be affected, but visceral organs can also be affected. I'm sure you've had patients complaining and they come in, oh, I have pain during my menstrual cycle. I have cramps in my stomach, but I'm getting pain in my back too, or pain down the leg. Because visceral problems can refer to the body. Body problems through the autonomic system can refer to the viscera. Sometimes lower digestive problems, irritable bowel is a great one, spastic colon, cramps in the lower abdomen, usually from poor digestion or stress, can also create trigger points, usually in the sacrum, the back. So you get these referred points. Treating those points can also help that problem and relax the viscera. The term strain counterstrain was developed by Dr. Lawrence Jones back in the 50s. He was an osteopath. He practiced manual medicine, manipulation, family practice. Great guy. He is no longer with us, but he was wonderful. I had the chance to learn with him directly. In doing the strain counterstrain, he discovered this, that treating a patient with general manipulation didn't always work. You get the person all doubled over. Oh, I bent for the soap, but I can't get up. They're like a pretzel. And he might work on them and find, gee, nothing's working. I have another patient waiting. You know how sometimes you back up patients because somebody has an emergency or you're just not getting results or you don't want to leave them hanging. So he'd say, get as comfortable as possible. Just lay on the table, sit, whatever you have to do. I'll come back in a few minutes and try to work with you a little bit. When he came back, he started to discover people with the same dysfunctions assumed the same comfortable position. So he said, wow, they've had a strain. If I put them in the comfortable position, it tends to make the strain lessen. Less pain, less spasm, and he put together a system of identifying that certain trigger points were associated with certain somatic dysfunctions, joint dysfunctions. And there were positions that eased those joint dysfunctions and helped people get back to normal postural symmetry. Less spasm, better mobility. So we said, hey, let's create this whole system of strain, counterstrain. Later on, after Dr. Jones has left us, some other people were creating new counterstrain positions. But because they weren't Dr. Jones, I guess they changed the name and called it positional release. So it's basically the same work. It's a technique using tender points or trigger points that there's an indicator of a dysfunction in the joint. And we're going to work with that by eliminating the tenderness with a comfortable position. Now, the characteristics of our positional release, you need to be able to position in such a way that the person is comfortable. You need to be able to find the trigger point so you know what to test before and after to see if it worked. And this is thereby an indirect release. We're going to be passively moving the patient into a position that feels good for that individual trigger point. Okay. Tender points can be identified. They're generally tense areas. They're tender to the touch. They could be superficial or deep. Remember that muscles are different layers of depth in the body. So if you're at the superficial muscles, the trigger point may be sensitive to light palpation. If it's a deep muscle, under other layers, you might need to dig in a little deeper to find it. So use the level of palpation force that allows you to feel the resistance from that muscle tension in the body. It allows you to palpate that taut band. And that's something you learn by experience, is practicing. If you get patients come in, they're like, oh, you know, when I push here, it hurts down here. And the doctor said I was crazy because those aren't connected. I said, well, unless you got amputated at the waist, sweetheart, they're very connective. What connects us across the back? Muscles, rectospinal muscles, from the occiput to the sacrum, the iliac crest. So anywhere along those erectors that there's trigger points can affect the tension through the rest of those muscles. And their fascia, their connective tissue. So we know they're related. These tender points or trigger points are often correlated very highly with acupuncture points, neurolymphatic points. So if you learn a little bit about those systems, Oriental medical system, you might also see some correlation there. There are many trigger points in the body. You could look at great books like those of Dr. Leon Chatow, who has made some trigger point charts of common trigger points in the body. You could take courses with the Jones Institute. So basically going to be doing a passive range of motion treatment. And what's the CPT code for passive range of motion? TheraX, right? Therapeutic exercise. So if you want to bill for this, one of the available codes is 97110. 97110. The code that I feel is more appropriate because we are re-educating the neuromuscular system. We're tapping into those reflexes that hold abnormal tension, so I recommend to use the neuromuscular re-education code, and that's CPT code 97112. So our theories, this is basically the theories are based on the work of Dr. Lawrence Jones and others, Dr. Kaur, Dr. Ed Stiles, and they say they're correcting a somatic dysfunction. A somatic dysfunction is basically a joint dysfunction, biomechanical alteration of tension across a joint. We learned way back in school, muscles have to have a certain length-tension relationship to work effectively. If a muscle's too short, can it contract strongly when it's all bunched up? Not very well. So we would call that active insufficiency. You might remember this from biomechanics. If a muscle is overstretched and it's too long, can it contract efficiently? No, that's called passive insufficiency. If it's too long, the actin and myosin filaments are too far apart to get together and get a strong contraction. So biomechanical disadvantages occur when you have muscles too tight on one side of the joint. Of course, that means the muscles are doing what on the other side? Overstretched, right? So we're going to be correcting this somatic dysfunction. And what's interesting is Jones's theory has actually been proven by some studies. And most of the studies on strain counterstrain are using that term, strain counterstrain, not positional release. And most of them are found in the Journal of the American Osteopathic Association. One study here had looked by Howell et al., group of researchers, looked at trigger points, tender points, in the lower legs as a result of Achilles tendonitis, plantar fasciitis. They did a few different studies, and they did EMGs before and after doing just strain counterstrain, and found a significant difference in the reflexes of the gastroc muscle. And those are specific reflexes that are highly studied on EMGs, not to bore you with all the details, but there was a significant difference just from doing the positional release. So we know it does affect reflexes. We've seen it on EMG. Somatic dysfunctions are something you could write about in your notes. Do you guys know what a SOAP note is? Subjective, right? Objective, assessment plan. Just one style of note writing, but it's very, very common. So subjective. Patient complains of something. Does Blue Cross care what the patient complains about? What about United Healthcare? Oxford? Anybody care what the patient complains about? We might. Okay? But the subjective changes will not get you paid. Will not get reimbursement. So we want to make sure we have objective measures, right? Objective. Objective makes us happy because it gets what? Gets us paid. This is good. So you get your objective and you observe. What do you see? Forward, and I'll abbreviate here. Forward head posture. They're rotated to the right and they're side bent to the right. So it's easy to describe the posture. The right scapula is elevated. I generally write it out in my notes, but in the interest of the brevity here, we're going to just abbreviate it. So we see the posture. It's going to be postural distortion. You can palpate. Start poking around in there. What do they feel? Palpate the upper traps. I think about the muscles that tilt them to the right. Upper traps, scalenes, right splenius, levator, right? These muscles coming back to us a little bit. Erectors on the right. So you palpate those and you decide, let me write down what happened with my palpation. So we palpate and we find that they have trigger points. Lots of big trigger points. And you find it in the right upper trap. You poke at it and they jump clear off the table. Oh, that really hurt. So do you write in the note, that really hurt? No, you have to grade this. How much did it hurt, my darling? On a scale of 0 to 10. 0 is no pain. 10 is the worst pain you could imagine. She's like, oh, that was a 9. So you have pain scale, 9 out of 10 for that trigger point. And for each and every trigger point that you find, name the muscle. And maybe it was right upper trap muscle belly. Maybe it was the origin, the insertion. Be specific, because you want to recheck this again later. So give them a pain rating scale, 0 to 10. And then you could check also. Look, she might have a loss of range of motion. So what do you think? Someone's all bunched up like this. What motion is difficult? Left lateral flexion, perhaps. So you do your range of motion testing. And you find that left, we'll call it left side bending, is only from 0 to 10 degrees. Would be nice if she had a little more than that, right? You may find that left rotation is only 0 to 15 degrees. And you can document this. So take out your goniometer, do some measurements. This problem might even weaken a patient. Could you imagine? So you could look and see muscle weakness. How do we measure that? Manual muscle test. I like to use a Nicholas handheld dynamometer. It's a fabulous handheld force gauge that can measure how many kilograms of force a muscle can generate or how many pounds. Depends on how you want to measure it. It also gives you a certain time to peak torque and so on in the muscle, but it's an easy way to get an objective measure. What is her strength before and after, and individual treatment. Strength can change within an individual treatment, and that's what I love about strain counterstrain. Initially, it was developed for pain reduction. Newer studies have shown that it also increases strength because we are decreasing the neurogenic inhibition that's caused by pain. So I put my patient on the table, face up, I do a standard manual muscle test of neck flexion. Say, how much can you pick up your head off the table? Now we remember that if she can pick up her head through a full range of motion against gravity, that's a 3 out of 5, right? 5 out of 5 is normal, 0 is nothing, so 3 out of 5, she could lift against gravity. This woman had a 3-. She could only pick up part of the range of motion against gravity, half her range. So we'd say her manual muscle test of neck flexion was 3- out of 5. I could have done extension and other tests, but you get the idea. You want something to measure before and after. I may find that her neck disability index, she may be 46% disabled. We would like her 0% disabled, right? Maybe the next visit I give her the neck disability index again, and she's down at 25% disability. I said, look, your disability went down significantly. You must be doing your home program. So we measure this, and you can measure before and after. So look for all of these objective changes. This way you have it all down. Then you do your magic. Maybe I decide, oh, she's so tight, I might want to warm her up and soften the muscles with some ultrasound. Perhaps I start with the modality, some ultrasound. And then I start to work on her soft tissue. She says, oh, it's too painful to stretch, too painful for you to dig in there. So instead, I might use positional release, counterstrain. Position her neck in such a way that we reduce the pain in the trigger point, reduce the spasm in the muscle, and she can move more easily. So then after I do those interventions, I'll give her a home program, give her some exercise to do, and I'll remeasure the strength, the manual muscle test, the trigger point. How is it now when I poke at your shoulder here, at your upper traps? Oh, I think the pain is about a 2 out of 10 now. Great, we had a 7-point reduction in the pain. So this is great documentation, and it's documentation you could do within a visit. I would find by the end of a treatment that she's able to pick her head up fully against gravity and even take a little resistance. That's wonderful, because now we see, look, we have an objective change. I could measure it with a handheld dynamometer, and that's even more objective. So use these tests to show that something has changed. And remember, everything in the body is connected, right? Do you think she had just a problem with her neck? Right? If her shoulder's up, she may be pulling into her back. The body's connected. So I like to look at the body holistically. We have what you call kinetic chain theory, the tensegrity model. Tensegrity is just a term for architectural integrity in the body. Right? If stuff is not lined up properly, it's not going to last too long. Imagine we're in a hotel right now. If the foundation of the hotel was crooked, would you want to be sitting here enjoying this seminar? Probably be out the door in a heartbeat, right? Building might fall. But in our bodies, our muscles know, hey, if we're crooked downstairs, we don't want the person to fall, so the muscles will tighten up and try to compensate and hold us in place. And every now and then, those compensations give way, don't they? People make appointments, they come and see us. So we want to make sure we realign the biomechanical integrity, have good symmetry, so the muscles are not overworking, not becoming too tired, fibrotic, etc. So everything's connected. So you want to restore the biomechanical integrity, restore the normal length-tension relationships across the joints. This is basic kinesiology. This is not that involved to do. So we're going to tune into our neuromuscular reflexes today, decide if they're abnormal in a patient using the evidence of a trigger point and limited range of motion and or weakness. We see there's a problem, and then we'll use our positioning this morning with strain counterstrain to reduce that sensitivity, to reset the muscle spindle sensitivity to stretch, so it's not so hypersensitive. Then this afternoon, the second half of the seminar, we'll use muscle energy therapy, specific contractions of muscle to either increase range of motion or to increase strength. So there's a follow-through. You need the whole picture. We'll find tender points in our partners. We're not treating them as a tender point per se, but we're using them as an indicator that there is a joint dysfunction. We can call that a somatic dysfunction. And a little trial and error of positioning someone passively will identify a position of comfort. Where is the point in the range which the pain reduced in the tender point or trigger point, they become less sensitive, and you actually feel the muscle soften under your finger. You really palpate that. The theory is that there is abnormal proprioceptive feedback after an abnormal stress, tension, trauma, etc. We want to alter that spindle sensitivity to make it less sensitive to stretch after an injury. And this is based on Jones's theory of strain counterstrain. He calls it a spontaneous release by positioning. Counterstrain is a mild strain applied in a direction opposite the original strain. Okay, and Dr. Jones made certain rules, and rules are meant to be what? How about followed? How about decide for your individual patient what's appropriate based on your clinical reasoning process? So sometimes the rules have to change. Jones says the pain is based on position. If you put the muscle on a stretch, it's going to make it more sensitive, make those muscle spindles kick in. The joint dysfunction is basically a reaction to some kind of strain. Maybe it was a slip and fall. Maybe it was a car accident. He says the antagonists hold the tender points. We'll take a look at that. I don't think that's always true, but you can check it out on your own patient. We're going to find a position of comfort, a POC, that makes that tenderness in the trigger point reduce, makes that muscle relax. And then we're going to hold that there for about 90 seconds. Some people who have high tone or central nervous system dysfunction might need to hold it longer. And it's been documented by some researchers, like Dr. Sharon Weiselfish has looked at people with CNS dysfunction, spasticity, and found they take like 5 to 20 minutes. So we might position them in a position of comfort, walk away, treat another patient while they're relaxing in that position for a while. Just another concept. When you take them out of that position, Your rate of return to neutral should be slow. I'm in New York, I'm always in a hurry. But here, I have to slow down. So just imagine going in slow motion. You don't want to reactivate that muscle spindle stretch reflex. You want it to calm down. So if you're finding it's not working, make sure that the patient let go. Make sure that you brought them out of the position slowly. I like to explain to patients, look, you have this pain in here. Yes, you're stiff, you're a little weak. We call that a joint dysfunction. Okay? Your muscles are acting as if they're still being strained even though the accident was 4 months ago. We never re-educated your muscles that it's safe to let go. I'm going to put you in a position that tells your muscles it's okay to let go now. All the strain is gone. And that's what strain counterstrain is. Okay? The muscle spindle has been implicated as the culprit of maintaining the joint dysfunction. Dr. Jones says when you're treating, position the muscle with the trigger point in its maximally shortened position. So as an example, the biceps would be totally flexed at the elbow, totally flexed at the shoulder, totally supinated at the forearm. Now, frankly, here's a rule I've broken many times. Some patients feel that's such a strain to go to a maximally shortened position. What muscle's being strained when this is happening? Triceps, lats, pronators, etc. So you're putting a stretch on the antagonist muscles. That's what's getting the agonist, the biceps, to relax. Remember reciprocal inhibition? Stretch one muscle, activate it, turns off the muscle on the other side of the joint. So we have a nice reciprocal inhibition. Guess what? You could get that without maximally shortening. For biceps, I might just get some release with some elbow flexion and supination. I might not need to elevate the shoulder. But if that's not working, I'll try it. So you could use any of the actions of the muscle, see what works on your patient at the moment you're trying, because it may be a little different treatment to treatment. We do this in slow motion. Make sure you hold it for at least 90 seconds. Give that muscle spindle a chance to re-educate, to let go. It does take longer if they have spasticity, and we're looking for the final outcomes. Decreased tissue tension, you can palpate under your finger. Decreased pain, measure using the pain rating scale. And interesting, increased strength. Very frequently that muscle can now be more activated, so you'll find a measurable increase in strength. That was not initially included in Dr. Jones' information, but in some of our students at Toro College in Manhattan, I used to teach there at Toro College, and when you're teaching, students are always bribed to get to do some study that the professor likes. So one of my fellow professors and I both enjoy Counterstrain. And this Dr. Wang had some students starting to do a Counterstrain study looking at the hip abductors. And the study was published in the Journal of Manual and Manipulative Therapy. So I can reference that for you later in the day. Fabulous study. We looked at normal patients who had tender points, trigger points in their hip abductor muscles, did a simple positioning, shortening, and within 90 seconds, the pain not only went down, but the strength was significantly better. And that was accepted through a good peer-reviewed research journal. We looked at the strength using my Nicholas manual muscle tester, handheld dynamometer, and that's been shown to be valid and reliable in the literature. So our treatment principles takes about 90 seconds. This is easy. We flex the flexors that have the trigger points, extend the extensors. Just passively do the action that muscle would ordinarily do on its own, shorten it, and you turn off that abnormal reflex. Little precaution, sometimes people are sore the next day. A little delayed onset muscle soreness may occur. Now the muscle is working differently. Perhaps part of the muscle that was not working before, was inhibited, is now working. It's working differently. They might be sore. Let them know. Teach them exercise before they leave. If they're very sore, you can give them some ice, teach them how to use ice. Typically, it's very mild. It's almost like they did some extra exercise today. They might get a little sore tomorrow. So our indications, muscle guarding, acute injury, joint hyper or hypomobility can all set up trigger points, abnormal fascial tension, and of course, any of these problems can contribute to deterioration in functional abilities and ADL. We can help restore those using this as part of our treatment program. Okay, the results you're looking for, you should be able to normalize the muscle tone. You can feel that tight muscle softening underneath your fingers, so you should be palpating and evaluating. You want to normalize the fascial tension, get better range of motion, measure with your goniometer, better strength, you can measure that with a dynamometer. And because this also relates to the autonomic reflexes, you might even increase circulation in that area by decreasing that inhibitory reflex, decreasing that vasoconstriction. So you get some nice results. Contraindications, the bottom line highlighted, anytime motion is contraindicated. We are doing passive motion for patients. So if that passive motion is contraindicated by a fracture, an open wound, an infection, or so on, maybe some medical hardware need not be disturbed, maybe they just had a spinal fusion that's not supposed to be disturbed, those may be times motion's contraindicated. So if you're concerned about whether or not they're allowed to be moved passively, do a great examination or refer to someone who can do an appropriate evaluation and make the appropriate referral. Perhaps they've had an orthopedic surgery and you don't know if that tendon repair is ready for passive movement. Check with the surgeon. Get it in writing. We're going to expect that you would do a full examination. Again, if you're not doing a full eval, refer to someone who does. Some of these people need x-rays, MRIs, blood tests. If that's not something you do in your office, you might want to refer out for that. You may have a patient coming in with neck pain who gets dizzy when she moves her head. You want to move her head and have her pass out without having her check with a neurologist. So this type of thing. Do a full exam. If you find there's trigger points, there's loss of mobility, maybe some muscle weakness, then you can scan, palpate, and record all the trigger points that you find. Give them numbers. How much did that hurt? That was a 9. How much did that hurt? Oh, that was a 2. And record those trigger points, and then prioritize. Which is the worst one? So I try to treat the most painful trigger point first. And then some of the trigger points around it might actually disappear from treating the primary painful trigger point. This way you don't have to treat a million. I'll usually treat maybe 2 or 3 trigger points in a day. And then I move into my muscle energy, my exercise, whatever functional things I need to do with patients. So this is part of a whole treatment plan. It's not the only treatment. And the techniques that I show you today that are listed in your manual are from Dr. Jones's work. The names of them are from Dr. Jones. And we're going to do some things you find typically in the clinic. Neck pain, back pain, elbow pain, etc. So we'll go through several joints of the body. And by the time we're ready for our second part, our muscle energy, you should have a concept of how to do this on just about any muscle. For the posterior neck, posterior cervical spine, we're going to be palpating points just along the spinous processes, over that upper trapezius and erector muscle group. For those muscles, most of those muscles are neck extenders. Some of those muscles rotate to the head to the opposite side, like your upper traps. Will rotate your neck to the opposite side. So to reduce a trigger point there, we'll position them with their neck extended, side bent toward the painful point, and rotated away. Now if that's not working, you may recall that don't some of the muscles in the neck rotate to the same side? Others rotate to the opposite side. Guess what? If it didn't work to rotate away, what could you try? Rotating toward. Okay, so upper traps rotates away. Erectors rotate toward. So if it's a really deep trigger point, you might think about, well, toward might work better because erectors are deep. If it's at the surface, it's more upper trap. Remember, muscles are in layers. So really remember your muscle actions. That will make you very precise in applying today's techniques. For the upper traps, what's that prime action? Upper trapezius. Shrugs the shoulder, elevates the shoulder. So you might find in someone who can't move their neck because maybe they have a acute herniated disc, you can work on the upper traps just by passive scapula elevation. And that could work very nicely as well. Or you could work from the neck by extending, side bending to that side. So you have choices. Knowing the muscles have several actions give you choices. Then we'll look into some of the posterior lumbar points. Jones calls these posterior lumbar points, but they're actually in the gluteal region. So we'll use the ilium and its landmarks as a reference, and we'll find what he calls the posterior third lumbar, posterior fourth lumbar trigger points. Just memorize your muscles, keep a list of muscle actions on your wall in the office, so you can refer to ones maybe you haven't seen for a while. Oh yeah, that's what that one does. Okay, we'll palpate for the trigger point, rate it on the pain scale with a number, and then experiment to see, get your partner ready, get them in as comfortable a position as possible, and then passively move them to reduce the pain in the trigger point. And it's also fun to check, gee, did they get any better range of motion? What else changed with that? Now in this you see from the picture that posterior cervical muscles generally are neck extensors, so we're going to need to extend the neck in order to shorten those muscles. Most of the muscles on one side bend the muscle to that side. Some of them rotate to the same side, some rotate away. And I'll mention this as we go through it. So if one rotation doesn't work to limit your patient's trigger point, which way will you go? The other rotation. So this is not rocket science. Basically, if you stick to your kinesiology principles of what is that muscle action, how can I produce the movement passively that that muscle does to shorten it, you should get good results. Here's the other thing. If that doesn't work, and the trigger point is still active, they're just as painful, what else might be going on? Maybe they have a tumor and that's what's hurting them, and Counterstrain will not help at all. That means they need referral, right? It's not working. That's an extreme. Perhaps they're inflamed. So this is not going to make inflammation go away right away. But if it's abnormal neuromuscular tension that's causing the pain and the problem, abnormal muscle spindle reflex telling the muscle to tighten, making it contract persistently with those tight bands, those trigger points, that will reduce with the positioning. So if you're not getting a reduction right away, give the patient also a moment to relax. Sometimes it takes people a while to let go. You know, when you're handling them, they're either helping you to move them or they're fighting you. You know how people do a little bit of guarding. So be aware of that. Give them a moment to relax. If you're fully supporting the patient's body part, they're going to let go. They'll relax. If you're not and your hands are shaking because you're trying to hold their head up in midair with no support, that would be a little bit of a challenge. They'll feel your tension, they'll tighten up, and thereby the technique won't work. So make sure your patient as fully relaxed as possible. Make sure that you are relaxed as possible. In the clinic, we like to have things like bolsters, pillows, etc. available that we could boost someone up with a pillow or a bolster. Okay? So let's pretend that Eddie has some trigger points in his posterior cervical spine. Now, Eddie mentioned that he had a history of a car accident years ago. Sometimes his neck gets a little stiff on the left side, but there was no major trauma. So check with your partner, of course with your patient before you examine them. Does he get dizzy when he moves his head around or tilts his head? If so, what will you do? Yeah, refer. Maybe do a vertebral artery test to see, is he having a problem with that? If so, someone says that right away, immediate referral to a neurologist. I don't want to get involved with someone having a problem. There's even documentation of people stroking out during a vertebral artery test because there's a decrease of blood flow to the brain. So if someone's getting dizzy, nauseous, or just very uncomfortable, we don't want to be moving their head into extension, rotation, or side bending. And vertebral artery test is generally the test for that. We refer them out and see how is their circulation going. Now, this is just a flat table. Sometimes in the clinic we have tables with adjustable headrests, which are a lot easier to use. But here, if you have a flat table, sit at the head of the table, put a pillow or something to rest his head on your lap, and it's easy to extend, side bend with good support. Okay, Eddie, I'm going to be feeling the muscles at the back of your neck here and seeing if there's any sensitivity or pain. If you have any pain where I'm poking, can you let me know? Mm-hmm. And then we'll ask Eddie, tell us on a scale of 0 to 10, how much does it hurt when I press? And the amount of pressure will be basically to match the resistance that I feel in his muscles. Compare right side and left side. Come just below the base of your head in the middle. The first spinous process, the first bony prominence you feel at the midline is the spinous process of C2. So palpate just lateral to C2. Go down one bump, one level. C3, palpate there. C4, and I'm doing this with Eddie as we go along. I'm feeling, does he have tight bands in his muscles? Do his muscles twitch when I roll my finger across them during the palpation? We got a little tension right there. Any pain in any of those?
Just a little tight right there.
A little tight right here? Mm-hmm. Okay, so C6, 7 on the right. I'm going to do a little bit of extension. Upper cervical points require very little extension. Side bend toward that side. And you may or may not try a little rotation and just rest your head there. Comfortable? Mm-hmm. Okay, so then we'll hold this position for 90 seconds. So it's easy to find in the middle, especially, of the upper trap muscle belly, there's often trigger points. I mean, who doesn't have a trigger point here, right? Any tension in any of these spots?
Right
there. And feel a few spots. You don't go just for the first one. Little tension here, too. Mm-hmm. There seems worse.
Yeah.
Okay. 0 to 10?
About 5.
Eddie, put your right hand on your belly. Just let it rest there. So I'll just reach over, grab his elbow, just go right up through the humerus, and I can palpate at the same time that I'm moving his shoulder, just using the humerus as a lever. And just let that kind of rest there. So you want him to relax. You might want to hold it in that shrug position. Any different here?
Yeah.
Any numbers?
Maybe a 2.
Maybe a 2, so not a 0 yet. Let's see maybe a little bit more elevation. Give him a moment to relax it. Any difference here?
Yeah, it's gone.
Gone. Okay? Now, just watch. Are you comfy to stay like that? I don't have to be touching him for this to work. The pure point of strain counterstrain is that the position is doing the work. And I could come back, and if you're good at your palpation, you could come back to the same point and know where you are. How's it now?
Good.
Good. So touching the patient is not part of the treatment per se. I like to have my hands on the patient because I can feel when that muscle's relaxing. Okay? I can also take this time to say, do a modality. If I'm working on his upper trap, I could put him in a counterstrain position. Say you wanted to use some heat and electrotherapy. You could go ahead and have the hot pack and electrodes on and leave him in this position as long as he's comfortable. If the shoulder shrug was not enough, I could have added the other actions of the upper trapezius, which would be side bending to the same side, extension, and rotation away from the trigger point. Into the posterior lumbars. Okay, so we're going to find some points in your hips, and I'm just going to use your left hip as an example. The upper lateral glutes have some tender points, and they're called the posterior lumbar tender points because they have to do with the posterior lumbar muscles. We'll pretend he has a back problem, and he's having some pain at trigger points in the posterior lumbar region, the gluteal region. According to Dr. Jones, the third lumbar point, P3L, posterior third lumbar point, is found by using the iliac crest as a landmark. The third lumbar point is found 3 centimeters inferior to the iliac crest, 7 centimeters lateral to the PSIS, approximately. We'll pretend that he does have a tender spot. Let's say he has, say, an 8 on a scale of 0 to 10, right in this posterior third lumbar. Now, if you're thinking about what muscle is under my fingers, oh, gluteus maximus. The origin of the gluteus maximus, iliac crest, lateral border of the sacrum. It comes inferior lateral to the greater trochanter and the iliotibial band. So it's helpful if you just cradle the leg, hold under the thigh here, and say you get some extension. Okay, let me try adding a little bit of abduction, maybe a little external rotation. Once you're there, this is a good time to get that pillow to support him so that you don't feel like you have to be holding his leg up the whole time. I'm just going to bring him back. If the trigger point was reduced after the 90 seconds, bring him back to neutral, and we'll just look at a different option of positioning. Eddie, lay on your side facing the audience. Imagine if I was extending his hip. And he said, oh, my back is killing me. You put my leg down. It's really hurting my back. So to help that with the back, if you want to keep the back a little flatter, a little bit more comfortable, bend your bottom knee up to your chest. Hold it with your hand. And just keep that steady right there. Comfortable? Mm-hmm. So say I'm on a point here. We'll say that the P3L is on the right side this time. I could easily do my lateral rotation. I want to just pull it up a little bit. There we go. And just rest your leg. I could do just lateral rotation and abduction and still treat the glute without extending the hip. Do you see how this is just another option? And side lying with the bottom knee bent and hip bent will keep the back a little flatter, a little more of a posterior pelvic tilt, and there's a lot less discomfort for those people with tight hip flexors or back problems, especially the elderly. They're not comfortable on their belly, so try that. The last choice would be supine. I could hang his leg off the table, keep his opposite knee bent. Just an easy way to go. Next technique would be the posterior fourth lumbar, which is located at the lateral aspect of the hip. To find the P4L, palpate the iliac crest. Palpate the greater trochanter of the hip. It'll be along the mid-axillary line, halfway between iliac crest and greater trochanter. This is actually in the gluteus medius muscle. So palpate. This is a hip abductor and medial rotator. So to release it, we use hip abduction and medial rotation. You can see that that leg rolled in at the foot. And then we're holding that for the gluteus medius. The last one would be the iliacus. The iliacus is a hip flexor muscle, and according to Dr. Jones, the tender point for iliacus is located in the lower abdominal region, halfway between the umbilicus and the anterior superior iliac spine. So palpate, where is that bump right above where his hip flexes? Anterior superior iliac spine, or ASIS. Here it is. So if you took a halfway point between these two, right in the abdominal region, and point directly into the spine. I like to use where the tendon trigger point is. Come inferior and just medial to it, right over that inguinal ligament, you can palpate the iliopsoas tendon. So say he had some pain here, it was a 6, we would want to passively flex the hip. So just cradle his leg, just bending your knee up toward your chest. So I might want to do a little more flexion, maybe add a little lateral rotation, and see how is it now. Oh, that made it go away. It's a 0 now. Excellent. And then we'll hold this. Most of these iliopsoas trigger points take more than 90 seconds to release. We'll pretend that that's completely gone. Let it go in slow motion, all the way down. And then, of course, you test again. How is it now? So the palpation is just to test. We don't keep poking. We're going to be finding some points in the subscapularis. Start with the arm in neutral along the mid-axillary line, would be neutral relative to shoulder flexion extension. To get there and find it, abduct his shoulder a little bit. Wait until you feel that scapula moving under your fingers here. There it is. Curl my fingers to the anterior border. So I'm on the trigger point, bring them back to neutral. And the treatment would be extension of the shoulder and internal rotation, which would be placing the hand behind the back. It's easy to manipulate this if you just hold him at the flexion in the elbow. Now I could just let him rest like this. If you couldn't get to a 0, I'll hold the anterior surface of the shoulder and just retract a little bit. If you had a patient in the sitting position, you could approach the subscapularis from behind, come underneath the axilla. Please do not compromise the brachial plexus by digging into his armpit. You'll feel the bush. Lift your arm a little bit just to see if I could feel where the border of his scapula is, and rest. I found the bone. I'm going to curl my fingers around the anterior surface. I could just let me bring your hand back here gently. You see how it's easy to do some of this just in sitting. You can use many different positions as far as sitting, supine, sideline, prone, whatever works for you to access that on your patient as long as they're relaxed. To find tender points here in the wrist, palpate from the lateral epicondyle, extensor carpi radialis, extensor digitorum communis, extensor carpi ulnaris. You could use your thumb or your fingertips, find a point, he gets a twitch reaction, use some gentle extension of the wrist, supination, and then holding. Now for the hamstrings, we're going to be palpating here, and let's identify the origin and insertion so we know what muscles. There's 3 major hamstring muscles. The common origin is the ischial tuberosity. If you come down medially to the medial, I'm just going to bend your knee a little here, medial to the knee joint, passing the medial knee anteromedial proximal tibia is the pes anserine tendon, right? It's a common tendon that has 3 muscles. In this case, semitendinosus is a hamstring that attaches here, but you also have the sartorius and the gracilis, which are not hamstrings, right? Okay, so let's just see. I wonder if he has any tenderness medially. Any tenderness in here? Okay, so he's good with that. Let's follow that semitendinosus up. If we come to the posterior medial proximal tibia, just below the knee joint, you're going to have the attachment of the semimembranosus. Okay, the other medial hamstring. Any tenderness here? And then follow those tendons up. You could feel them if you just bend his knee a little and he tightens up. You could feel those tendons. I'm going to follow the tendons up and see. Sometimes the trigger point's in the muscle belly. Sometimes it's in the tendon. And I'll follow it up. Frequently, I find a big trigger point right in the middle of the posterior thigh. Let's now check the lateral hamstrings. That's going to be the biceps. Again, same origin, but the short head of the biceps come to the posterior lateral proximal tibia. The long head of the biceps comes to the lateral knee, just at that fibula head. Check for tender points throughout the hamstrings, including the ischial tuberosity. If, say, he has a tender point in the medial hamstring, flex the knee, test the point again. Still bothering, you could use a little bit of internal rotation, or you can extend his hip. I'm going to just pick up your leg and put some pillows under there. Some hip extension with the knee flexion. You okay with that knee? Feels good to me, feels loose. And then that will get a nice trigger point reduction for the medial hamstring. I want them to see that I'm cradling his knee to protect his knee, and I'm holding his hip. And back, and then test the point again. There we go. Okay, good. That's the hamstring. Last. So yes, it released on the table today. Will the patient still have it later today? What about this afternoon? What about next week, next year? And I was very happy to say I have no clue. Okay? Because there hasn't been enough randomized controlled clinical trials studying these techniques to say that this should last X number of days, weeks, or months. But here's my clinical experience speaking. There are studies, and they're in the Journal of Manual and Manipulative Therapy, and particular studies done in the Journal of the American Osteopathic Association, and they looked at people with back pain. And they found that with Counterstrain, they rechecked the people with back pain 6 months after they were discharged, and did find that they still had range of motion that have improved, less pain in their back, and increased functional ability measured, I believe, by the Oswestry Back Disability Index. So that's one of the reasons I like to use the disability indices to see, as the patient is progressing with therapy over a course of maybe a couple visits, can we document each one on a disability index and see if there's a change that's functional. And that type of functional change I can mail right to Medicare, my back disability index or the hand disability index, whatever you're treating, you could send it out. So the only documentation I've seen is that 6 months later they did check for people with back pain. My typical response from working with patients in the clinic, say they come in and their back is just strained, they were lifting too many packages, they work at a job where they have to do heavy lifting, they strain the muscle, maybe they have a bulging disc, they come in, they're 10 out of 10. They can't stand up straight, they're limping, maybe they're using a cane, they're on a lot of medication. So this is like a classic patient. Maybe I get down to a 7 or a 6 today. And he's not as antalgic. Now he can walk up straight, he could walk a short distance without a cane. Okay, that's a nice start for today. That person who's very acute, I'm typically seeing 2 or 3 times a week. And I'm going to be doing many interventions, not just strain, counterstrain. But if they're primarily in pain and moving them makes it worse as far as active movement or stretching, I might want to calm down the trigger points first with the strain, counterstrain, and then go into my muscle energy, contractions or stretching I might want to need some mobilization on them to readjust their vertebrae. It really depends on what they need. If someone is having a herniated or bulging disc, I might use a modality such as traction. So I won't be able to put them near a traction machine if stretching them is making them worse. I won't be able to get in and give them exercise if stretching is making them worse. So that's a prime time where I'll say, look, the neuromuscular system is really on a high alert. Those muscle spindles are very sensitive to stretch. Stretching hurts. Let's try non-stretching. Let's try Counterstrain. And that would be a perfect time I'd use Counterstrain first. And I would expect that their trigger point score, the pain score when they come into therapy, is lower each visit. Maybe the second visit he comes in with a 7 out of 10 on the pain scale. He leaves, he's a 3 out of 10. Comes back in next time, he's a 5 out of 10. It went back up again, he was doing his daily activities, aggravated it. Comes back in, now he's down to a 1. Next visit he comes in, he's a 9. What happened? Oh, I really tried to lift something again. I know you told me not to do it yet. But inevitably, life happens and people come in. If they're doing the same thing that caused that abnormal neuromuscular tension, they're going to rebuild their trigger point because the body will respond. So the key is, if the trigger point is there because they're too weak to do ADLs, we have to have strengthening programs. You know that takes some weeks to accomplish. If they're stiff and their stiffness is causing problems because they've forgotten to stretch or they do things unevenly with their body, sitting at the computer with bad posture for hours, 6 to 8 hours a day, that might cause problems. If we don't go ahead and show them the ergonomics, how do you sit at a computer with proper body mechanics? How do you break up your day instead of sitting there all day, get up, stretch, do certain exercise? They'll rebuild the trigger point. So we need to look at the whole thing, what's happening with this person, that the problem's coming back. So if they're doing all the right things, the exercise is starting to work, they're carrying over, they're compliant with home programs, you figured out something that they're doing at work or home or during their sports that's aggravating the problem, and you corrected it, the problem's gone. So really work with each patient individually. If the problem is not going away, refer for extra examination. Run some extra tests, maybe there's something else you're missing. Okay? I had a young lady who came into me not long ago, wonderful young woman, about 23 years old, just finished graduating pharmacy school. And she was so excited. She went to her first job, she's working 12 hours a day. A little expensive living in New York, most of us work 2 jobs. So 12 hours a day, she's screwing and unscrewing jar caps. And she didn't have to do that in school, and she's never done that in her life. Could you imagine how her wrist felt and arm from screwing and unscrewing child-proof caps all day? So she came in with tennis elbow and a wrist sprain. She had a referral from an orthopedic surgeon. Now, most surgeons will do an x-ray when a patient comes in. Even if they don't think they need it, well, let's bill it out, so let's get that x-ray. She did not have an x-ray. I thought this was very curious. I said, I'll do some mild stuff with you today. She had all the normal orthopedic textbook signs and symptoms of lateral epicondylitis, tendinitis of those wrist and finger extensors, a little bit in the flexors, and some pain over her wrist, over her distal radius, not the wrist joint. So I did some ultrasound to her forearm muscles. I did some gentle strain, counterstrain. She thought it was magical. It went from a 9 to a 0. She said, this is great. I gave her some very gentle exercise, and of course I told her, you must take a break from all this screwing around with these jar caps, right? Not a good thing to do. How about if you wore a brace for a little bit, give your wrist some support. She's very inflamed. And she said, oh, I can't. It's a new job. I'm afraid to tell him I hurt myself. I don't want to lose the job. And then the whole drama goes on. I said, well, then find somebody to pawn these jar tops off on. Get someone else to do it for you. Maybe there's an intern. Maybe there's an aide there to help you. Maybe they have a machine they didn't tell you about to help put the caps on. You imagine that could be exhausting. She comes in the second visit. I felt great after therapy, but the pain keeps waking me up at night. And then she comes in the third visit. She felt great after the second visit. Comes in, same thing. Trigger points back, still has pain in the wrist. I said, I know you went to an orthopedist and he's well regarded by your family or whoever sent you over there, but you really should have had an x-ray on your wrist. I have a bad feeling about this. You should be feeling much better. Because she did do less. She did some of the jar caps, but less. She went to a hand specialist I sent her to who took an x-ray. Guess what was giving her pain that's waking her up at night? Key, waking me up at night. Cancer. Okay, you hear that. This girl basically had more than a nose drip growing up. Perfectly healthy, very happy. No reason for her to have a giant cell tumor in her distal radius. Plus, she had tennis elbow on top of it. So here's a situation where this is not working. Within a visit or two, something's missing. She went right in for surgery and had that removed twice. Okay, so of course she had to still work with the tennis elbow, but can you imagine that a giant cell tumor is infinitely more important than a tennis elbow? And she ended up going into research or something. But just an example, do a full exam. If the full exam is not done, a piece is missing, they're not responding, you absolutely must refer for additional evaluation, right? Makes sense. Now, you may notice in the book, the pictures are slightly different than what I'm showing you. I'm doing that on purpose for everything so that you learn to be flexible. Some patients can't lay prone. Somebody else will be very cranky when you put them in supine. Maybe their shoulder hurts, their hip hurts. You need to know that you can change the person's position. Can you figure out how to treat a hamstring if the person's sitting in a chair? Can you figure out how to treat a hamstring by hanging their leg off a table, which is a picture in your manual, versus can't I do this in sideline? Knee flexion, hip extension. So as long as you can position the joint to shorten the affected muscle holding the trigger point, you should be able to do that in most any position, sitting, supine, maybe even standing. Some of my runners who get the Charlie horse in their hamstring, I'll show them how to do some of that positional release. So, you know, hold on to something with one hand, grab your other leg. They can do their own hip extension, knee flexion. We usually call that a quad stretch. Isn't a quad stretch a counterstrain for the hamstring? So you can reason this out. Be aware there's lots of choices. That's the beauty of this work.